So I'm a consultant neurosurgeon. I've been in Leeds for just short of 14 years as a consultant. I've got a mixed adult and paediatric practice. So that's looking after the newest of newborn premature babies through to oldest of old people. So full breadth. I do a lot of work because of children's neurosurgery. There's a lot of children with spina bifida and related conditions that I look after. Alongside that, hydrocephalus, a lot of brain tumour work with adults and children, and then also other things like Chiari and syrinx when you've got fluid inside the spinal cord as well. So quite a broad breadth of things, as well as emergency things like brain trauma, brain injury as well. I've got a busy medical legal practice, which is a fun challenge. It's very interesting doing the expert witness work because the contrast between units, actually there's a lot of similarity between units. On the whole, a lot of things are actually very standard and things have been done well, but there are times when sadly things have gone badly. And sometimes that's just because of the standard complications of that surgery, and sometimes it is because people have failed to recognise the warning signs, and there have been problems because people haven't listened to the patient or looked at the warning signs, and so mistakes have been made. And it's always a challenge to go through. It's always interesting as well looking at the claimant perspective or the defendant perspective, because there are several times when I've seen things where actually the claimant actually just wants answers as to what's gone on. The why has this happened? Was this really abnormal, or was this actually something that could have been explained? And times when you also get told, well, why wasn't I told that? Why wasn't it explained in that way? Now that makes some sense. Thank you. That sort of thing as well. So it's not all about, oh, I'm going to sue the backside off someone. It's about trying to get some answers. Why am I in this position? Could and should things have been done differently? Spinal dysraphism is an overarching term. It describes all the different types of spina bifida, spinal abnormality related to spina bifida. So that's the sort of parent global term for all of it. But before we go into that, basic anatomy. So, sheet of paper. When the egg and sperm come together, the cells of the embryo line up as a sheet. In the middle of that sheet, the cells start to roll together as a ridge. And then that ridge folds in on itself and curls in. And curls in like that. And in the center here, this becomes the spinal cord. It zips up, that sort of curling in and zipping up starts in the middle and works up and down. And the middle where it starts is basically the middle of the back of the chest, and it zips up all the way forward to here, so it includes the brain, and all the way down to your bottom, so the full length of the spine. So the brain and spine are made by that curling in process and zipping up. If that process goes a bit wrong, then you end up with these various forms of spina bifida and can have some brain abnormalities into that mix as well. It's a complex series of things that can go wrong, because anywhere along that, if a single skin cell, for example, gets pulled into what becomes the spinal cord, then you end up with skin cells growing inside where the spinal cord is. And that forms a ball of skin-like cells, which is called a dermoid. Dermis, skin; dermal, dermatology, skin; skin cells inside the spine, dermoid. Similarly, if you get a fat cell going in, you end up with fatty cells inside, mixed in with the nerves and the spinal cord, and that ends up with some fat cells in there, so that's your lipoma. And the spinal cord, when it first forms, because it's the full length, you have full length spinal cord, and then there's a bit of what we call caudal regression. The spinal cord shortens a bit That's a natural process that doesn't always go quite right. So sometimes you end up with a long spinal cord. Sometimes you end up with some tethering, some fixing of the spinal cord at the bottom, where that regression, where that spinal cord coming up hasn't quite gone right. And as I was saying also, with that curling in that you get, if you get a skin cell dragged in, you can end up with a tract running from the skin into where the spinal cord is. And that's a potential communication, which may be a real communication where fluid is coming out, or it may be the tract, the remnant of that communication. And we never fully know how much that is a full passage where bacteria or organisms can get through there into the spinal canal, or whether it's just the fibrous remnant of one. But it's certainly something that when we see it, it's a warning sign of trouble. So if we've got that tract, that's referred to as a dermal sinus tract. Dermis, skin. Sinus, because it's a thin channel, and tract, obviously, because it's a tract running through. So there's lots of different things you can end up getting on. When we've got a patient with a form of spina bifida, spinal dysraphism, it's then a case of trying to work out exactly what is the anatomy of what's going on, and then how do we explain that to the family? Spina bifida with no movement of your legs, well, that's a very different thing from spina bifida occulta, for example, where it's occult, it's hidden, and you may have normal movement of your legs, you may have normal bladder and bowel function. And then actually I find generally saying to a family, oh, your child's got spina bifida occulta, they pick up on the spina bifida and they go, oh, loss of leg function, loss of bladder and bowel control, wheelchair. So I try and pick my terms so that I try and explain things, trying to avoid too much of the technical jargon because it's not helpful. Yes, they need to know what the diagnosis is, but they need to know what it means for little Billy or Ella or whatever other random name I can think of. What does it mean for their kid as they grow up? The simplest of all those different sort of bits of spina bifida and things, the simplest one is the spina bifida occulta and the dermal sinus tract. Yeah. Those are the ones with the best, typically with the best types of prognosis, because the more complex spina bifida, where the spinal cord comes up and is there on the skin, that will inevitably have nerve injury. And then the lipomas are also potentially complex depending on configuration. But so for example, a dermal sinus tract has got this tract of fibrous tissue that runs in, attaches to the spinal cord. If there is a tract there, if it's weeping, it's something where we would generally say, we advise surgery early on, cut out that tract, take it down to where it's joining the spinal cord, seal it off fully from the inside, coming back out, get rid of that, and then you should hopefully have a normal prognosis moving forward. The next one related to that is when you have the spinal cord regressing back up, you have this fibrous tissue running down from it called the phylum. Everyone has a phylum. Sometimes that phylum can be thickened and sometimes it can contain some fatty tissue within it. So it can be a phylolipoma. There can be a thin bit of fat within the phylum. So a thickened phylum or a phylum lipoma, again, is a generally fairly simple thing to treat. And it's something that will often be treated in a young child because if the spinal cord is held low, doing an operation to come in, cut that thickened phylum is a fairly straightforward thing to do, fairly low risk, very unlikely to cause paralysis and bladder and bowel problems. And it's protective because as the spinal cord grows, as the child grows, they're not having the extra stretch put on it because of that point where it's pulled on. And that point where it's pulled down and held down low, that's a form of tethering. So a thickened phylum and a phylum lipoma is a fairly benign form of tethering that's fairly easy to treat. We can watch it or we can operate. And that's a discussion that we have with families where we sort of just explain the pros and cons of operating early versus observing. The danger of observing is that once you start to get change in nerve function, so some leg weakness or some bladder and bowel loss, once you then operate, you're operating to stabilize the condition rather than necessarily bring about improvement. Prophylactically, you can prevent that future deterioration. So you take the risk of surgery up front, but the benefit is avoiding the deterioration. So a thickened filum and a fatty filum is a fairly easy thing to treat. You go in, you chop it, nerve monitoring to make sure you're chopping the right thing and that you're not disturbing nerve function. But actually, it's a relatively safe operation. And that's why we can do it early. That's why we offer it early, because it's protective and low risk. Whereas the lipomas, where they're mixed in with the nerves and attached to more of the spinal cord, they're much more complex. And for a lipoma, the tendency within the UK has certainly been historically to wait until there's symptoms before operating on them. If this hand is the spinal cord with the nerves coming off it, if the lipoma's on there attached to the spinal cord and nerves, you've got to try and peel it away, and then you're risking injuring the nerves and the spinal cord. So if I'm going to risk injury to those, I want to know that I really do need to do it. The first thing that usually happens is problems with bladder control. Now, the real difficulty here is, obviously, a 0-year-old child does have bladder control because they wee, then they're dry, they wee, then they're dry. So we can ask parents, are you seeing that your child's nappy is wet and dry and wet and dry, or are they constantly wet? Similarly, with passing poo, passing stool, you can ask them, are they constantly dribbling small amounts of poo, or is it episodes where they have a distinct bowel movement? And the nerves that control bladder and bowel are essentially the same set of nerves. So we can ask them about that. But it's relatively subjective, can be relatively difficult. So until that child starts to actually show interest in continence, in potty training, 2-3 years old, it's quite difficult to tell that more objectively. And even then, getting a 3-year-old to tell you whether things feel normal or not. So this is where there's difficulties. But yes, bladder and bowel tend to be the first things to go. Those nerves are more sensitive. They're the most distal nerves. They're the furthest down coming off the spinal cord. And those are the nerves that are usually affected first. And then after that, we can see things like weakness in the ankles or the feet rolling out or curving out, abnormal foot position. Once we've seen that, that's a later sign. And if we see that, coupled with knowing that there's a spina bifida type abnormality, spinal dysraphism, then again, that's a sign that the nerve function is impaired. Now, again, the question is that nerve function impaired since birth, or is it a relatively new thing that's progressive? And so is now the time to intervene because we've got that, or are we just seeing the natural history playing out here a bit more? And that's often quite difficult. And that's where we need to be careful with the discussion with the family as well about the best ways forward of what to do. So essentially, the majority of spina bifida patients, of any of the types of spina bifida, spinal dysraphism as the overarching term, the majority of those patients should be under regular follow-up, looking at bladder function, having ultrasounds to look at, are the kidneys emptying satisfactorily? Are we getting any signs of problems with the kidneys? Are they getting recurrent UTIs? Kids with your classic spina bifida, where they've got some problems with leg control as well, we know they have bladder problems as well, so they should already be on intermittent catheterization, often multiple times per day, right from the time of birth. If a child has got apparently normal continence, then they do still need some ultrasounds of bladder and kidneys to make sure that function is okay. They also need orthopedic follow-up, looking at the hip position, looking at leg growth and monitoring that leg growth and looking for leg deformity as well as they grow up. So the bulk of this will end up with a generally under a paediatrician. For example, we've got one of our local paediatricians in Bradford has got a special spina bifida clinic where she has regular urology input, regular input from the orthopedic team as well, and she sees the patients on a very regular basis, is doing the bladder scans on a yearly or twice yearly basis, and is doing regular follow-up, because as a paediatrician she's got the overarching way of being able to sort of look at everything, be the conductor of that orchestra, pulling in people when she needs them, monitoring head growth and the head circumference as well, looking for signs of hydrocephalus. So it's that's ideal when you've got a paediatrician taking that overview, because as a neurosurgeon I'm very focused on just nerve function, spinal cord. I've got very much a bias on that rather than the other bits, and that's where we rely on having good paediatricians in the community settings to do the more overarching care. Telling the parents what to look out for, like you both asked earlier, knowing, right, bladder problems, that's something key, that's a warning sign. We're watching for, your kid has got a lipoma, your kid has got some tethering, so the spinal cord is held down low. As they go through growth spurts and the spinal column grows up, the spinal cord is getting under some degree of stretch, actually day-to-day movement, side to side, forward and backwards, that's producing some degree of stretch force on the spinal cord as well. And if it's tethered at one point, it's not able to move as freely. And so all these things, day-to-day movement, growth in particular, can be points when we see problems develop with patients with tethered cord. And if we've told the families, look out for bladder problems, they can flag that early. Yeah. And they need to flag that early, because that's our warning sign. That's right, get a repeat scan, consider whether you can do something surgically to help improve things for this kid, help prevent that deterioration. Couple of things. One, don't let the fact you've got a spina bifida kid put you off having another one. Yes, it can be stressful, and yes, it's a bit of a moment, but actually at the end of the day, do your family how you want your family. Don't let medical things rule that bit of life. And don't be afraid to ask.